chairpersons, dear professors, and dear colleagues. It's my pleasure to have this active participation in such a unique conference, CardioEgypt 2024. Our case presentation is simple. Let's start. We start by the history. Mr. EF is 40 years old man, married with three offsprings. Neither diabetic nor hypertensive, complaining of epigastric pain with no relevant cardiac complaint, for which seeking the medical advice, where he accidentally discovered an abnormal rhythm, so it was referred to our cardiology clinic. 10 years ago, the patient had history of previous attack of palpitation, for which he admitted in our CCU for 3 days. During this admission, the echo findings was normal, with normal left ventricular ejection fraction, and he was managed by anticoagulation and intravenous drugs for 3 days. On discharge, he was in medical treatment, which stopped after a few days, and he didn't seek the medical advice again. Now, he is completely asymptomatic regarding the cardiac complaint and has a good functional capacity with no limitation of normal daily activity. On examination, he has an average body build and has 80 beats per minute irregular rhythm, equal in both sides. The blood pressure was normal and normal GVP, no lower limb edema, and the chest and heart was clinically free apart from variable S1. And this is, as we see in the ECGs, was showing irregular heart beating with no clear, definite P-wave morphology and irregular RR interval supporting the diagnosis of EF. On our investigation, then the lab test was normal regarding thyroid function, normal liver and renal function, but the recent echo has this strange and astonishing information: dilated left atrium. The atrium is dilated around 4.7, and dilated LV dimensions and left ventricular ejection fraction is 40% by M mode. So how to manage Mr. EF? Which type we have of EF? It is paroxysmal, persistent, or permanent EF. What about the long-term anticoagulation? And finally, rate versus rhythm control. Thank you.
Thank you very much, Dr. Ahmed. I think we are going to answer these questions after the session. Some of the answers we are going to find out. Professor Gamal Fahim apologized for attending this session, and now we are introducing Professor Massimo Trito. He's going to give us a talk about the earlier the better in EF ablation, a revisiting concept.
Thank you very much, Ms.
Thank you.
Chairperson, dear friends. It's a great privilege and an honor for me to be here today. I'm very glad. Can I have my slide, please?
Would you like to have a mic?
No, the slides. Okay.
Slide.
How does it work? I cannot see them. Okay, thank you again. So, as we will see in the next presentation, it would be expected to be the previous one, but it will be the next presentation. Atrial fibrillation and heart failure, whatever the phenotype is, reduced, mid-range, or preserved ejection fraction, are closely related because of either from the pathophysiological and clinical standpoints. And as you know, they share common risk factors and mechanisms leading to one condition may promote the occurrence of the other one and vice versa. Finally, in the clinical setting, they they do commonly coexist, and when this occurs, it significantly worsen the outcome of the patient by increasing the risk of hospitalization, of stroke, and of death. Catheter ablation has the potential to interrupt this vicious circle by stably restoring sinus rhythm or reducing AFib burden, as you can see in this rather paradigmatic case, a patient with very poor left ventricular ejection fraction, which became almost normal after catheter ablation. The role of catheter ablation in heart failure patient has been evaluated in the last years by several randomized clinical trials that are summarized in this table. Overall, they have enrolled roughly 2,500 patients with a mean age of 65.2 years, mostly male with paroxysmal with persistent atrial fibrillation and reduced the left ventricular ejection fraction. The results of catheter ablation were compared with those achieved with rate control or the rhythm control, mainly using antiarrhythmic drugs. And despite none of this study provided any definitive conclusion on this topic, overall they demonstrate that catheter ablation halves the risk of atrial fibrillation recurrences, 37% versus 73%, and it is associated with a significantly greater improvement in left ventricular ejection fraction, 10.8% versus 4.4%, with a 60%, roughly 60% difference between the two figures. And this left ventricular recovery might be predicted using scores like the ANTERVEP 1 that has been recently validated in this relatively large multicentric cohort of patients, more than 600. This score includes 4 parameters: the presence of structural heart disease, wide QRS duration, severe atrial dilatation, and paroxysmal AF phenotype. Obviously, the lowest score indicates the healthier subjects, those who have a very high, more than 90% chance to recover left ventricular function after ablation, whilst the highest score identified the sickest patients with a very poor outcome after catheter ablation. This functional improvement then results in also in a significantly better quality of life and exercise tolerance, reduce the rate of hospitalization for decompensation. The relative risk is reduced by more than 25%, the absolute more than 5%, and most importantly, it significantly lowered the all-cause and cardiovascular mortality. The relative risk reduction is 39.5% and 48.6% respectively. At least this result, despite this result can be, when ablation is performed by expert investigators like those involved in this trial, this result can be achieved with an affordable risk in terms of complication. Major complications are less than 1%, and they are pretty comparable with those of medical therapy. Nonetheless, some open questions still exist. The first one is whether these results do apply to the general population with heart failure. The population enrolled in this trial are relatively small. They are very likely skimmed. We have to remember that only 13% and 21% of screened patients have been enrolled in CASTLE-HF and CASTLE-HTX studies, and mixed. They have enrolled different HF phenotypes, predominantly with reduced left ventricular ejection fraction. And also the amount of pure tachycardiomyopathy is largely unknown, and this is an important point because this condition do impact on the patient outcome. So very likely the proper answer to this question presently is not yet. And thus, not surprisingly, the most recent guidelines recommend to perform class 1 indication with level evidence A, or to consider class 2A indication with level of evidence B, catheter ablation in appropriate patients that are those with reasonable expectation of procedural benefit with atrial fibrillation and heart failure due to reduced or preserved ejection fraction, respectively. And the best candidate should be the younger patient without significant other comorbidities, with paroxysmal or early persistent atrial fibrillation, probably not the one that I showed Hamad before, with tachycardiomyopathy, when tachycardiomyopathy is suspected or it is demonstrated through electrical cardioversion trial, at early stages of heart failure, that is left ventricular ejection fraction greater than 25% or near class 1 or 2, without or with mild atrial fibrosis at MRI or electro-anatomical mapping, and without significant ventricular scar as demonstrated by the camera MRI study. And the second question is whether atrial fibrillation timing may impact on the patient outcome. In this respect, atrial fibrillation catheter ablation is considered a second-line therapy in most clinical settings. However, long wait times before ablation expose patients to a relevant risk, roughly 20% of the death outcomes, including death, atrial fibrillation, heart failure, hospitalization, or emergency room visit. And at least from the theoretical standpoint, earlier intervention could be associated with a better outcome because of less extensive electrical and structural atrial remodeling. In this respect, the E study demonstrated that a rate control strategy, also including atrial fibrillation ablation, when started earlier, that is, after the first year from diagnosis of the arrhythmia, may result in a significant improvement of a composite endpoint, including cardiovascular death, stroke, or hospitalization for heart failure or coronary acute syndrome. And either in the general population of the study, minus 21%, as well also in the subset of patients with heart failure, predominantly with preserved ejection fraction, minus 26%. So moving now to catheter ablation in the general population, larger retrospective series summarized in this rather recent meta-analysis demonstrated that earlier ablation is associated with a significantly better success rate. And most importantly, it can prevent the progression from paroxysmal atrial fibrillation into persistent atrial fibrillation, as demonstrated by the long-term results of the early AF study. Once again, this conclusion cannot be considered as definitive, since they have been challenged by the recent publication of this randomized trial, small randomized trial, which failed to demonstrate any benefit with early ablations compared to delayed ablation. And moving to the population with heart failure, we have no data from randomized clinical trial. The only information comes from the large retrospective series like the one as shown in this slide, which again demonstrate a significant benefit in terms of mortality when ablation is timely performed, either in patient with or without heart failure. And these are my conclusive remarks. Atrial fibrillation catheter ablation in heart failure patient is feasible, effective, and safe. It should be timely performed, or at least considered, in a selected population, younger patients, those with tachycardiomyopathy and heart failure with reduced left ventricular ejection fraction, to improve symptoms, quality of life, ventricular function, and cardiovascular outcomes. And finally, properly designed studies are nonetheless required to address presently unresolved issues, that is the role in larger population with different HF phenotypes. Thank you for your attention.
Thank you, dear professor, and would like to stay with us till the end, stay on the ground.
Okay.
And now,
There are questions for Professor. Any questions from the ground for Professor Massimo?
Yeah. Thank you very much for such a very terrific lecture. My question is the level of heart failure. Of course, it will vary of the results. If it is below 20, ejection fraction below 20%, the results will be lesser than those of ejection fractions about 40, isn't it?
Yeah.
And what's about the early? What do you mean by early? It is a chronic AF.
Yeah.
Yeah.
I know it's not easy to address this question because it's very difficult to say when it is early. Most study, at least when they try to understand whether atrial fibrillation ablation works better or not, they use it as 1 year from diagnosis of atrial fibrillation as the target to cut these two population. For heart failure, of course, it's not easy, and probably we have to use the same in the population with heart failure. The occurrence of atrial fibrillation should be the red flag to put attention on that patient and try to treat this arrhythmia, preferably with catheter ablation as soon as possible. This could be a way of doing, it's a reasonable way of doing in the clinical practice. I mean, this is what we try to do nowadays.
Okay. You also mentioned that indications of AF ablation include younger population. So do you have a definition of younger population? Because we see the AF in a large percentage of patients over 60 and over 70, and we would like them to get back to their normal life without atrial fibrillation. And there is also the question about anticoagulation in these patients. So,
okay, the first question, I have no clear response because there's no absolute definition of young patients. Of course, we have to distinguish, we have to consider the biological age of the patient instead of the angiographical age of the patients, and we have to also look at the frailty of the patient. So frail patient must be excluded from ablation. With or without heart failure cannot be treated or should not be treated with ablation because they have a very poor response and a high risk of complications. The other people, again, it depends on we have to put together several conditions together: the age, the biological age, the structural damage of the heart, the atrial enlargement, the left ventricular, the ejection fraction. All of this together maybe should prompt us to afford or to suggest or to not suggest ablation. So this is, in my view,
so a patient who's 70 years and is not frail, he's well.
No,
and
70 years for me is a relatively young age.
Okay. So I needed to hear this because in Egypt, young is always 20. Above 20 is old.
No, 70 years is a relatively young age, but over 80 years, but maybe we
consider he's getting older.
Yeah. And regarding anticoagulation, depends the risk, the thrombotic risk of the patient. If it's greater than 3, it's not recommended to withdraw anticoagulation after ablation. So they have to continue anticoagulation even if they are.
I mean that if you don't do ablation, we have to give him anticoagulation at this age.
yes,
So
yes.
this is my concern. I mean,
Again, there is quite good evidence from post-hoc analysis that elderly patient can be safely treated with the direct anticoagulant. So it's better to continue to consider this therapy also in this population.
okay, thank you very much. We have to move on to the next speaker. Actually, this is going to be Professor Mu'taz Zaki from Alexandria. He has a tremendous work in electrophysiology and in AF ablation. So we are going to hear his talk about using ice or fire. Does it matter in AF ablation outcomes?
Dear professors and colleagues, thank you for the lovely introduction. I'm here to learn, actually, so thank you for the good words, kind words. So after we heard about ablation in atrial fibrillation, AF ablation in atrial fibrillation with heart failure, what modality should we use? Should we use the traditional radiofrequency ablation or cryoablation? So to begin with, back to our patient, he's a younger age, okay? He's 40 years, so I think young by all definitions. He had, yeah, very young. So, okay. In Italy, very young. Maybe in Egypt, just young. So, not very. Okay. So he had, this is the second attack of atrial fibrillation. The first one was 10 years ago. And at that time, his ejection fraction was preserved. It was 60%. So, but now I find with the new episode of atrial fibrillation, his ejection fraction, which was delivered to me during the presentation, which was delivered to me on my email, it was 45. Okay. So so it's okay. So it's 40 to 45. Okay, with a somewhat dilated left ventricle, and also a dilated left atrium of 47. According to this patient, he's not actually a heart failure with a reduced ejection fraction, either 40 or 45, because it's more than 35. So he's considered a mildly reduced ejection fraction patient. In the range of 40 to 50, mid-range. So mid-range was the previous definition. Now they say mildly reduced. Both are the same. So
Class 1.
yeah.
Class 1. Yeah.
Yes, and class 1, he's asymptomatic now. So this drives me to the classical, study, The Fire and Ice, which was published maybe in 2016 by Karl-Heinz Cook. Why? Because he excluded patients with ejection fractions less than 35%. So our patient fits into this study. His ejection fraction is 40 or 45. When it was sent to me, it was 45. Okay, so, but now he's 40. And also the left atrial diameter was less than 55 in this study. So our patient fits in this category of patients. What did they do? They randomized not a lot of patients, maybe 300 patients in each group, to radiofrequency ablation versus cryoablation. And what are the results? Basically, both were equivalent in terms of the primary efficacy endpoint, as well as the randomization by the use of the catheter itself. So archetic front, the older generation, also the archetic front advanced, newer generation of cryo, using smart touch with radio frequency and also without smart touch, the traditional radio frequency, all had the same outcome, no interaction between groups. And this is very reassuring that all technologies actually work for such patients. And in all subgroup analyses, even with larger left atrial diameters, more than 41 versus those less than 41, all had were comparable, and they received benefit from ablation. This didn't come at a cost of a safety endpoint. So both modalities were safe. There was a trend towards more safety, non-statistical, with cryoablation actually. Why? Because actually it doesn't infer pulmonary vein stenosis risk as much as radiofrequency. Incidence of tamponade, atrioesophageal fistulas were lesser. So there was a trend towards lesser complication risk with cryoablation. The most prominent actually side effect with cryoablation is phrenic nerve palsy. Most of it, 9 out of 10, are actually transient phrenic nerve palsy, which recover within 3 months up to 1 year even. So only one case had phrenic nerve palsy after 1 year, one from 370 patients. So this is less than actually 0.5 or 0.3%. Again, cryoablation conferred less times, less left atrial dwelling time, less procedure time, less fluoroscopy time. This was significant. And these are all advantages for actual cryoablation. Not only this, but secondary analysis in the trial showed that repeat ablations, as well as direct current cardioversion, the need for DC for subsequent AF, as well as rehospitalization and cardiovascular rehospitalization, or were less actually with cryoablation versus RF. And the quality of life in both was comparable in the longer term. So the conclusion actually said that cryoablation energy conveys less repeat ablations and less DC shocks and less rehospitalization, which is actually crucial and important in our situation here in Egypt, because these procedures are costly, so we don't need to do repeat procedures, again, very costly, hospitalization. This is a more recent study, the CircaDose study, 2019. It randomized actually similar cohort of patients to cryoablation with 2 protocols, 2-minute versus 4-minute cryo, as well as contact force pulmonary vein isolation. And again, tachyarrhythmias after the follow-up, whether symptomatic or asymptomatic, were equivalent in all 3 groups. So this is very reassuring. Also, freedom from recurrent tachyarrhythmias was the same, comparable between all groups. The AF burden was very much reduced, up to 0.5% in all 3 groups. However, maybe radiofrequency had an edge in terms of the time to first persistent AF attack. The time. So actually, with radiofrequency, you prolonged the time to the first attack of atrial fibrillation. But this is very minor, and actually, given this, they conclude that given the similar rate of arrhythmia recurrence and AF burden, it is unlikely that the quality of life would differ between groups. Again, another trial reassuring that both modalities are equivalent. What about those with ejection fractions which are lower than 50%? So this is study, actually a small study, randomized 79 patients with HFrEF and mid-range ejection fractions. And it showed that all parameters improved either with cryo or RF in terms of ejection fractions, NT-proBNP, glomerular filtration rates, as well as the need for diuresis. All were actually comparable, as well as the freedom from atrial fibrillation in the longer term and survival rates. Again, so what about a meta-analysis? So on cryoablation, it concluded that actually a meta-analysis of 9 studies that cryo AF ablation is effective in heart failure with a reduced ejection fraction. Here, ejection fraction is even lower than 35% compared to radiofrequency ablation, and the complication risk was low. So, dedicated study on AF and heart failure. This is the Castle AF by Nasser Marouche. And we all know that ablation was superior to, not cryo, but ablation, radiofrequency, to conventional therapy with antiarrhythmics in terms of all-cause mortality. And however, the AMICA trial, which was published later, showed that very sick patients with ejection fractions in the range of 20%, those actually with scarred LV, very poor and frail, actually they didn't convey benefit from ablation, and they concluded that if you wait long enough to do AF ablation in very sick population, they don't benefit. But that was actually contradicted by another study, a very recent one, just published 4 months ago, the Castle Heart Transplant Study, also by Nasser Marouche, the group. They randomized patients with low ejection fraction in the 20s to radiofrequency ablation versus medical therapy. And surprisingly, this trial was stopped early, only after 1 year of enrollment. Why? Because there was a very significant reduction of 75% of mortality when using AF ablation versus amiodarone and all classical anti-failure measures, including sacubitril valsartan. And the ethical committee felt that we cannot leave those patients to die, and they switched over the medically treated group to the ablation group only after 1 year. You can see the hazard ratio of 0.24 in favor of ablation therapy in those very sick patients who actually had survival benefit, as well as the rate of implantation of left ventricular assist devices was significantly lower. The rate of conversion to heart transplant in this very sick population was significantly lower in this study. Quite a provocative study in very sick actually AF patients with very low ejection fractions, and I think this trial needs to be discussed with Professor Massimo to elucidate its discrepancy to other studies in the past. Of course, there are the cohort of patients between all those studies are different. They are not all the same. So maybe the Castle AF showed good benefit because the ejection fraction was a little bit higher. Some of them were paroxysmally. The NIHA 3 or 4 were lesser than other trials. So that's why maybe they conferred benefit versus other trials. One word about PVI durability and repeat ablation. It's very important to see that cryoablation in many studies didn't need redos as much as RF. Because why? RF we do point by point, and so many gaps can occur in the immediate future or even in the late future, rather than the cryoablation, which uniformly can make a uniform lesion without gaps. And this is shown here, and this has an economic impact. So for that reason, cryoablation, even in the Western countries, in Germany, conveyed a more economic solution of AF with heart failure. And we have to think always about that when we are tailoring the therapy for our patient. And I thank you very much for your attention.
Thank you very much, Dr. Sorry. That was really it's a highly scientific lecture. For myself, I got benefits a lot. So you prefer cryosurgery. What's about the skilled hand? Is it the same or needs more experience?
Yeah, exactly.
This is one question. Another question that about the recurrence. You said that the recurrence rate in the cryosurgery is minimal, or in comparison to the RF, it is more lesser than RF. So what's about the expenses as well?
Yeah. So these are all very good questions. First of all, the learning curve. So we all know that radio frequency application with the use of 3D mapping system, CARTO or EnSight, is a highly demanding in terms of technical consideration, as well as learning curve, experience, expertise. No standardization of the approach. Some do wide area ablations, some do box isolations for the left atrium, some do point-by-point segmental isolation, lines, roof lines. So a lot of discrepancy, no standardization, a lot of learning curve. You need to have a very high volume of patients to learn the skill set to do radiofrequency ablation. This is not the case for cryoablation. So cryoablation is anatomically based. You just go with the cryo balloon in all pulmonary veins, you occlude the veins completely, and you just push a button to deliver the cryo energy, and it does all the work for you. It circumferentially isolates each vein. It is easier to learn, a very steep learning curve. You don't need a lot of cases to acquire the knowledge. Maybe this is better suited for our community because, as well as not only this, but the recurrence rate and the reconnection rates of the pulmonary veins is lesser with cryoablation, as was shown in many studies. This has economic impact. Also, the cost per procedure is lower with cryo versus RF.
Very good.
So yes, it is very good, but again, not all cases can fit. So you have a standard balloon size, 28 millimeter. If you have a very big pulmonary vein, it will not occlude. You cannot do cryoablation. If you have a common pulmonary trunk, pulmonary venous trunk, accessory pulmonary veins may be difficult to isolate. So you have to tailor the approach.
Any question? شكرا دكتور معتز.
Thank you.
Now, okay.
We can take the comment from Professor.
Thank you. Congratulations for presentation. I believe that actually the results of Kessler HTX, yeah, are a little bit overestimated because the population is not probably so sick as they intended with the title of the paper. 30%, more than 30% of them were in near class 2, and I don't understand how these people can be in the active list for transplantation. They should not be. If you look at the dimension of the atria, they're not that large, so that means probably they are not so advanced at their failure, and this can explain the very good result in this population. The other point is that as for the first Castle study, there was a very, very huge selection of patients before randomization, and only 20% of screened patients were eventually enrolled. And this is another big limitation that indicates that this population is not the overall population we see every day in our clinics or in our hospital.
Selection bias, yeah.
Yeah, there is a very big selection bias, and this is why this study cannot provide to date any definitive response to for guidelines.
Yeah, but yeah, I agree with you. But the first Castle study, the guidelines took a class 1A recommendation for AF ablation because of the Castle AF,
Yeah.
with all those limitations that you said. So
I believe that these guidelines prompt to perform catheter ablation because most of the study, all studies demonstrate that there is a benefit.
yeah,
All studies are consistent with the results, so there is no contrast between them. But actually, none of them is definite.
yeah.
We have to have much more information to recommend class 1 with level of evidence A for all patients with heart failure.
Yeah.
Until that point in time, we have to select the patient. We have to look at the single patient, decide on the basis of the clinical characteristics, expectation, and the structural characteristics with the candidates that can benefit and with the candidate that cannot benefit. And finally, a comment regarding the redo ablation in patient with submitted to cryoablation. Actually, if the success rate is the same in radiofrequency ablation and cryoablation, I would expect that the redo rate would be always the same. The fact that the patient is submitted to redo or is submitted to cardioversion depends on the decision of the patient, depends on the decision of the physician, and this is a bias of the data. We cannot say that with cryo we do less redo because the burden on AFib is the same, the recurrence rate is the same. Why we should perform less redo? Yeah. It depends on the single population, the single patient that decide to perform or not. Depend on the physician that decide to ask the patient to do or not.
Valuable comments, Professor Massimo.
And now دكتور الحسين زهران Professor of Cardiology at Azhar University, patient perspective and shared decision making in AF management. تفضل دكتور حسين.
It's a pleasure to participate in this conference under the organization of Massachusetts and the Linear University. My lecture about patient perspective and shared decision management.
مش بتنقل
AF is the most common sustained cardiac arrhythmia in adult. Estimated prevalence about 2 to 4%, and two-fold rise is expected. About 44 million individuals with AF in 2016, and 35 to 50 AF patient carry risk for hospitalization and mortality in 5 years. So we have to integrate management to have better outcome, and many studies that report that integrated management with shared patient decision making improve outcome. Center of this approach is patient agreement and participation. And there is many career and many specialists participate in management of the AF patient. We have lack of patient education, lack of patient knowledge about AF and its management, which often limited, and there is lack of adherence to treatment, and factor affecting adherence to treatment can be grouped in patients related according to demography or comorbidity, cognitive impairment, and polypharmacy. Also, physician-related knowledge, awareness guidelines, and expertise, multidisciplinary team approach, and healthcare-related work setting, access to treatment, insurance, and many studies report significant lower rate of cardiovascular hospitalization and death with integrated care and shared decision making. So the guidelines recommend that to optimize decision making, shared decision making about AF treatment option, inform patient about advantages, limitation, benefit risks associated with treatment option, discuss potential burden of treatment with the patient and include patient perception of the treatment, recommend to routine collect patient report outcome measure to success and improve patient care, integrated management with structured multidisciplinary team, including healthcare professional, patient, and family health care. Patient report outcome measures should be collected at baseline AF diagnosis and every 6 months post-diagnosis and every 12 months. So long-term collect the data about long-term consequences of AF, mortality, ischemic stroke, heart failure, hospitalization, ATL high rate, ATL fast tachycardia, AF, anticoagulation, complication, follow-up complication of treatment, hemorrhagic stroke, life-threatening bleeding, serious adverse effect of intervention, medication side effect, and collect the patient report outcome about quality of life, physical, psychological, emotional, and cognitive function, exercise tolerance, ability to walk. In American guidelines, we have 3 pillars of management of patient: stroke risk, assess, and treat, optimize all modifiable risk factors, symptom management, rhythm control, or rate control. And this pillar should be achieved by shared decision making to treat risk factor and enact behavior. الحقيقه البيشنت لو يعني احنا عندنا البيشنت لو ما ركزش معانا في العلاج، يعني هو السكور بتاع العلاج، فانا ممكن ابقى عندي جايد لاينز وكل حاجه والبيشنت ما يبقاش في ادهرنس او في كومبلاينس مع التريتمنت. في اليوروبيان جايد لاينز تريتمنت اوف اي بي سي باس واي: اي انتيكاجوليشن، بي بيتر سيمبتوم كنترول، سي كوموربيديتي اند كارديوفاسكولار ريسك مانجمنت. A anticoagulation decision making to avoid stroke. First, in decision making is to identify lower risk patients who don't need antithrombotic therapy. Step 2, to offer stroke prevention to patients with risk factor, male more than one non-risk non-sick stroke, male more than one, female more than two. Step 3, choice between of oral anticoagulant between NOACs and oral anticoagulant vitamin K antagonist. So with a patient eligible for oral anticoagulant, patient mechanical or prosthetic valve ombilical severe mitral stenosis, vitamin K antagonist. If patient no prosthetic or mitral valve stenosis moderate to severe, identify low risk. Low risk, no thrombotic antagonist, no antithrombotic. If patient not low risk, calculate CHA2DS and has lead to modifiable bleeding risk. If a CHA2DS male equal 1 risk or female 2, class 2A or anticoagulant. If male more or equal 2, or female more or equal 3, or anticoagulant class 1 indication, and choice between NOAC or vitamin K antagonist. Also, the risk of stroke should be reassessed regularly, and atrial high rate episodes of subclinical AF burden. If short, rare atrial high rate episodes of subclinical AF, patient with low risk, single risk, it's a nuisance bystander. If high risk, increase observation for more high rate episodes or subclinical AF. But in patient with longer or more longer subclinical AF or atrial high rate episode, more 1 hour to 24 hours, or more longer, more than or equal 24 hours, with low risk or single risk, increase observation for atrial high rate episode of subclinical AF. If high risk with this patient, consider oral anticoagulant, which is red zone. B, rate for this rate versus rhythm control. Our target of treatment is to improve quality of life and prevent morbidity and mortality. First, rate control, what's the background therapy in all patients, is the first choice with no or minor symptoms. Therapy after failure of rhythm control, therapy when risk of restoring sinus rhythms outweigh benefits. So, first, lenient rate control, heart rate below 110. If still symptoms or deterioration of LV function or patient on CRT B or D, so we have to strict control heart rate and continuous to achieve, with patient with CRT, to achieve continuous biventricular pacing. So we have to consider rhythm control or even with ablation if symptoms persistent or deterioration of LV function or tachycardiomyopathy persist, or continuous biventricular pacing in CRT is not achieved. Rate versus rhythm is a debate from all time, and started with AFFIRM trial. AFFIRM trial 2002, 5 years follow up ل 4060 عيان، وكان البوبوليشن بتاعهم فيها يعني الحاجات المهمه ان الديبريسد ال بي فانكشن كان 26%، والايج كان مين ايج اكتر من 69، والريزلت كان مفيش امبروفمنت، بالعكس كان في worsening with rhythm control في البرايمري والسكندري اند بوينت، وكان significant في الهوسبيتاليزيشن والبراديكارديا والفنتريكولار اريزميا. بس زي ما هنشوف ان كان في امبروفمنت في اللو ايج او اليونجر ايج، هنا محددها 65 سنه، كان في better improvement with rhythm control also with reduced ejection fraction. So as we're going to trial other trial until to reach AF shift trial, this compared group of reduced ejection fraction اللي كانوا في better improvement من الأفيرم trial، وللأسف ما كانش في improvement برضه، no difference in clinical outcome. احنا بناخد بس جيرني سريعة في الترايل، فما كانش في difference فكان المحتمل ان يكون ده نتيجه للسايد افكت اوف انتي اريزميك دراج، فقالوا نعمل انتي اريزميك دراج فيرسس ابليشن. ده اللي كاس الاف ترايل. الكاس الاف ترايل about 3013 eligible for this study, but دخل فعليا 397 عيان و divided into group ablation versus conventional، وكان في significant reduction primary و secondary endpoint in ablation arm. So it has had impact to guidelines in 2020. يعني بنشوف ان patient paroxysmal or persistent AF in heart failure reduced ejection fraction referred directly to CAS ablation plus one indication in 2020. ASTFN trial. This trial was early rhythm control therapy with patient atrial fibrillation to assess if early rhythm control therapy can reduce cardiovascular risk AF less than 1 year. And ASTFN trial concluded that early rhythm control therapy was association with lower risk of adverse cardiovascular outcomes than usual care among patients with early atrial fibrillation and cardiovascular condition. So as mentioned by our Professor Dr. Massimo and Dr. Mu'taz, rhythm control as a preferred therapy is first episode symptomatic patient slight rate control, congestive heart failure precipitated or worsened by AF, young AF patient to avoid chronic electrical and anatomical remodeling that occur with chronic AF. C, cardiovascular risk factor and concomitant disease detection and management. We have to primary prevent AF by lifestyle modification, AF risk factor modification, treatment underlying condition, and if the patient, AF patient, secondary prevention by correction or management to modifiable risk and the partial modifiable risk. My take-home message: shared decision making in AF management is recommended over the paternalistic model. Inform patient about advantages, limitations, and benefit risk associated with treatment option. In general populations, the benefit of rhythm control over rate control remains better symptom control. There is growing evidence that plays a role of rhythm control strategy in heart failure population and early in course of the disease. Therapy should be tailored for each individual patient according to age preference, comorbidities, and most importantly, symptomatology. Thank you.
Thank you very much, Dr. Hussein. A very nice talk. And of course, we all know the old debate between rhythm control and rate control. However, for a while, rhythm control is the mainstay for all treatment strategies from all guidelines. If there is any question from the...
تسأل وتجاوب بقى حضرتك.
لا
حضرتك أستاذنا
لا
يعني.
لا عفوا، ربنا يخليك والله، ربنا يخليك. Thank you for the excellent lecture. I have a question for you, and also I would like to know the comments of Professor Massimo on two debatable things. The first of which is pill in the pocket anticoagulation. So this is a new era. I think there is a randomized study which was published in the United States, REACT AF trial, on patients' paroxysmal atrial fibrillation, very low Shands VASc score, 0 to 1, very infrequent attacks, 1 every 6 months. And for those, you don't need anticoagulation all the time. Whenever he has the attack, but he can feel it, symptomatic, then he takes a pill in the pocket anticoagulation and maintains for 1 month afterwards. And also take pill in the pocket anti-arrhythmic. So both anticoagulation and antiarrhythmic, and then he doesn't need to take prolonged. So this is the first one. The second one is a very also provocative study, which is called frail AF trial. So those patients who were frail, very elderly, above 80 years, had sarcopenia and osteopenia, very frail patients. When they were shifted from warfarin to NOACs, even apixaban, which is the safest, they had significantly increased bleeding risk. And also the signal towards higher mortality with the shift from warfarin, which was considered unsafe, to the more safe NOACs. So in this subset of a population, they concluded that it is better to leave them unswitched on warfarin, so long that they were controlled in the past with a good time in therapeutic range. I would like to know comments of Professor Massimo and of course you.
والحقيقه يعني البيشنت تشويس والشير ديسيجن ميكنج مهم جدا ان اقول للعيان، يعني مثلا العيان مش ما عندوش ريسك فاكتور، فاقول له ان مش نو نيد فور انتي كواجوليشن اكوردنج تو جايد لاينز، وان هو بروتكتد، وان الاستادز بتقول ان مفيش ريسك فاكتور عليه، مفيش ستروك. فهو للاسف احيانا البيشنت يبقى يعني ياخد من نفسه، وده بنشوفها كتير، لكن في النهايه انا بوضح ده للعيان وهو هو بيعمل بقى اللي بيعمله. الحاجه الثانيه ان بنشوف فعلا في الكلينيكال براكتس ان البيشنت بيرتاح على الورفرين، تيجي تنقله على اي ادويه ثانيه هو وخصوصا مثلا بيشنت تشايلد بيرنج بيريود with menstruation, bone ache and bleeding. البيشنت احيانا بيبقى ليه تشويس، يعني بيقول ان هو يعني بيشوف الهازاردز معاه وهو توليريت ولا لا. واللي يهمني الادهيرنس، وان الوارفرين يكون تايم ثيرابيوتيك رينج 70%. لو ما حققتش ده فلازم ياخد نوت.
So, of course, the first point is it's very interesting way of treat the patient. Of course, use anticoagulant on demand. The point is that all, even people with symptomatic AF, they have at least 50% of them, they have at least one episode of asymptomatic AF. So the protection in these individuals would be incomplete. This is the first reason. The second one is that there is no strict time relationship between the episode of AF and the thromboembolic events. It may precede, may be concomitant, or be followed by many months after the episodes. And this is another point that make difficult to use this strategy. And the third one is that even patients that are being implanted with a monitoring device or with a pacemaker, when this strategy have been tested, resulted in non-consistent results. There are some studies that have tested this hypothesis and they demonstrated no benefit with the intermittent anticoagulation. So to date, probably we have to follow the recommendation of guidelines and prescribe, offer anticoagulants to patients that are at high risk and avoid anticoagulants in those patients with a very low risk. This is the current knowledge, at least. And the second was frail. Yes. I believe that frail AF people are the most risky people. So probably they should also interrupt sometimes anticoagulation when they are very, very frail. So the point is to try to understand what is frailty, to pick up the patient with frailty and select them, and also try to prevent frailty. This is the next step in the future. So we have to treat, this is better to have to introduce guideline support therapy in this patient in order to prevent frailty and make this people may take also rather risky therapies.
Okay. Exactly. Okay, from the last slide from my presentation, how to manage Mr. EF, which type of EF we are facing? We are facing I want to change.
Just on the floor, what you said, this
the near atrial fibrillation.
So we are
Correct?
discussing paroxysmal, persistent, permanent. Till now, we don't have the real answer because the first presentation managed with no documented duration, but the patient at this episode was symptomatic, the first one. The second one is completely 10 years ago. This second episode is completely asymptomatic. It was accidentally discovered, so the duration is unknown. So we try to do Holter, which is the most longest monitoring method here in Egypt. The ideal speaking, we are dealing with implantable root recorder to understand we are facing with paroxysmal persistent or maybe long-standing persistent. So what is the aim from Holter? We to decide which type of EF we are facing. The second one, to estimate the EF burden. What is the EF burden? EF burden means the time that's spent by the patient in EF. So it can manage and give us the feedback of our treatment. So by our result, we have persistent EF because the 7 day, 1 week Holter monitoring was completely in EF. So we are dealing with paroxysmal type, we are dealing with persistent EF type, which is could explain. Exactly. This could be explain the structural changes which happen in the left atrium and left ventricle. The second question, the long-term oral anticoagulation. As said by Dr. Hussein, we are facing with person with a CHADVASC1 because he has documented LV dysfunction in form of, even if it is symptomatic, we are dealing with LV dysfunction ejection fraction 40%. So we can go up for further step by the recent guidelines, by 2023 ACC guidelines, which add additional risk factors that increase the risk of stroke not included in CHADVASC score regarding the higher AF burden with no definition, clear definition of higher AF burden and longer AF duration, which is maybe the present in our case. The second is the persistent or permanent AF type versus paroxysmal AF, the enlarged left atrium, which he has in our patient, and this number is already written by the recent guidelines, 4.7, and if there is obesity, and this is not our case, and poorly controlled hypertension. These additional risk factors not included in the CHADVASC score, and also doesn't give us a number or increasing the risk, but the cumulative presence of these risk factors, as in our case, long duration, persistent AF type, and with enlarged left atrial appendage, left atrial diameter with already reduced ejection fraction with CHADVASC1, support the decision to anticoagulate the patient. We have a discussion with the patient shared decision making in form of discussion of the possible option regarding no anticoagulation with NOACs or warfarin regarding the bleeding risk, cost, and maybe also the daily usage of the drugs either once per day or twice per day. And we finally, after this discussion, we decide to use doxapan 60 milligram once daily. Rate versus rhythm control. This is the issue.
Why doxapan?
Because once daily,
Doxapan once daily.
but maybe the patient, by discussion, maybe he has some GIT problems, the upsets that could be limitation for the use of rivaroxaban because it's, but this is a patient preference actually. Factors favoring the rhythm control, as we see the young age, the suppose the tachycardia-induced myopathy, or few comorbidities and presence of enlarged left atrium. So we have like mix of criteria supporting the rate versus rhythm control. But the recent guidelines by the American College of Cardiology stated some nice recommendation. The first of all, in patients with reduced ejection fraction, especially in persistent or high burden EF, a trial of rhythm control should be recommended to evaluate whether the EF is contributing to reduced left ventricular ejection fraction. The second one, in case of symptomatic, and this is the case of our patient, we are dealing mostly with high EF burden, EF type, and with reduced ejection fraction. So the trial of rhythm therapy, which is not ablation, and we are deciding the rhythm control, just rhythm control, is recommended, supposing that this reduced ejection fraction caused by AF. In patient with symptomatic AF, rhythm control could be useful to improve the symptoms, and this recently put in the guidelines. In recent diagnosis of EF less than 1 year, rhythm control can be useful to reduce hospitalization, stroke, and mortality. In patients with EF and heart failure, rhythm control can be useful to improve symptoms, improve the outcomes like mortality and hospitalization. Level of evidence 2A, we have the patient rhythm control strategy can be reduce the likelihood the AF progression, which may be the case. This is the case of AF progression. We are dealing with the complication of AF in form of reduced ejection fraction and enlarged left atrium. And in class 2B, in patient with EF, where the symptoms are uncertain, like in our case, a trial of rhythm control, here stated by cardioversion or pharmacological therapy, may be useful to determine if there are some symptoms attributable to AF or not, to test the patient is really symptomatic or asymptomatic. And class 2B, in patient with AF, rhythm control strategy may be useful to reduce the likelihood of development of dementia or worsening of cardiac structural abnormality. So, exactly, okay. We decide to go with rhythm control using the elective cardioversion and amiodarone to use in stable LV dysfunction with possible alternative dronedarone and catheter ablation, and could be
It's something used to be done in all intensive care units.
exactly.
Yeah, the problem now, what's about the valve? No valvular disease.
No valvular disease, no significant valvular affection, either the mitral or
Such a patient.
and such patient, yes.
No valve.
No valve. Okay. And we conclude by take-home messages that the EF is a disease of progressive nature. Consider additional risk factors for stroke prevention beyond the CHA2DS2-VASc score. Be flexible, especially in patients with CHA2DS2-1. And maintain the sinus rhythm as early and as effective as possible to reduce the AF burden and to stop AF progression, as this is a complication of our patient management, because in this long duration, maybe the AF type could be progressed to more persistent or permanent AF type. And thank you.